Let's have a look at abnormal venous hemodynamics. So we know that venous return relies on the pressure gradients of our respirations and of the cardiac influence, what's happening in the right atrium. We also know that venous valves help to prevent retrograde flow and reduce hydrostatic pressure. We also rely on a muscular pump to help accelerate blood from our lower extremities up to the right atrium. So that gastrocnemius contraction or calf muscle contraction helps to propel that blood. We also know that transmural pressure is the difference between the venous and tissue pressure. High transmural pressure means that the venous pressure within the lumen is higher than the tissue, and low transmural pressure means that the tissue pressure is higher than that of the venous pressure. Distal venous pressure standing rises to about 80 millimeters of mercury. So transmural pressure increases. Capillary perfusion across the arterial to venule side, those red blood cells moving from the arterial to venule side of the capillary bed slows. Venous return slows or ceases, and cardiac output is reduced. So what helps with venous return? The soldiers fall down, hydrostatic pressure is returned, and venous return can happen again. So remember, we discussed that this is a delicate balance. So when everything is normal and the arterial and venule pressures are normal, the pressure gradient is maintained. When we have an increase of venous pressure or that transmural pressure, we get a leak of that fluid into the interstitial space, and reabsorption doesn't happen. We also get a reduction of that pressure gradient between the arterial, so the red blood cells start to slow between the arterial and venous venule side of the capillary bed. So we have a decreased pressure gradient and a decrease of venous return. We also know about respirations when we breathe in and breathe out. So with inspiration, we have a reduction of thoracic pressure. So what happens in the upper extremity venous return is it actually increases, and that's that increase of venous return to the heart. During expiration, we actually have an increase in thoracic pressure, and flow in the upper extremities starts to slow or cease. So the flow in the lower extremity veins is driven by the abdominal pressure, and venous return from the upper extremity veins is driven by the thoracic pressure. We also can look at the cardiac influence and what's happening in the right atrium. During systole, the pressure starts low and slowly rises. So right atrial filling is happening, or venous return is happening. During diastole, that tricuspid valve is wide open, so pressure is low, and the right atrium is continuing to fill. During atrial kick, or right atrial contraction, there's a spike in pressure, so that last squeeze of blood going from the atrium to help fill the ventricle. And this is what it looks like over here. We have systole, diastole, and atrial kick. So the 5 characteristics of venous flow: we have unidirectional flow toward the heart. It's phasic, or pressure changes happening with our breathing. It augments with distal compression. And when we bear down or perform that Valsalva maneuver, lower extremity venous return ceases. And all of this, of course, happens spontaneously. So abnormal findings, abnormal cardiac findings. We have a normal systole, diastole, atrial kick. It's almost like a W is what they call normal venous return. And we see this in our systemic veins everywhere. Let's have a look at what happens when we have an increase of right atrial pressures. Look at this. We have this very pulsatile up and down flow. We lose that nice W of the systole, diastole, and atrial kick. So what's happening is those right atrial pressures are rising over 8 millimeters of mercury. So those normal pressures of the right atrium are 0 to 5. So when we see something like this, it's important to ask the patient if they have a history of cardiac or pulmonary disease. So let's just kind of have a look how blood returns here. Blood returns through the SVC, IVC into the right atrium, out to the right ventricle, out into the pulmonary artery and out into the lungs to be reoxygenated to head back into that left atrium. So you can imagine, let's grab a good color here that we can see, that if the pulmonary pressure rises, or the pressure in the lung rises, in here, then basically what's going to happen is these pressures to allow for blood to move out into the lung, the pulmonary arterial pressure begins to rise, which in turn causes an increase in the right ventricular pressure. And because blood is moving from the right atrium into the right ventricle, we have an increase of right atrial pressures. So we need a higher right atrial pressure to overcome the higher right ventricular pressure. So we need a higher right atrial pressure to cause that tricuspid valve to fly open and allow that venous filling to happen so it can get out to the right ventricle, pulmonary artery, and reoxygenate it. So what happens is eventually we see this reflected, these higher right atrial pressures reflected into our systemic venous system, and it's a pulsatile venous flow. So we also get abnormal findings here. If you notice, we have our undulation of pressure changes with our breathing. In the second one, we kind of get this low velocity continuous flow. So if we think about what's happening here, we kind of have an increase of pressure. So with lower extremity, it would be an increase in venous or in abdominal pressure. So flow ceases. So you can imagine that if we draw out the system, and this is an increased pressure, you can imagine that something compressing into the IVC is falsely elevating that pressure. And what happens is we lose the that respirophasic change, and pressure changes aren't reflected distal to that. So anything that is low velocity flat flow is a proximal outlet obstruction of venous flow. So meaning that it's proximal to our location in space. So if we were to see this waveform bilaterally, then we know we have to look more proximal, and more proximally would be the IVC. So some kind of pelvic tumor, fibroids, pregnancy, ovarian malignancy, lymphadenoma could be some causes that would be compressing the IVC. So this is an indicator that our study isn't over and we need to look more proximal. If we were to see this, if we had our spectral tracing here and we only saw it in the femoral vein, it would be unilateral, just meaning the one side, and it would be somewhere proximal to where we are in space. But again, if you saw this finding bilateral in both common femoral veins, you would need to look more proximal, and that would be IVC, so proximal outlet obstruction. Okay, now when we take a big breath in and we bear down, we are going to get a cessation or stoppage of flow with normal venous return. And what stops that? It's our venous valves helping to prevent that retrograde flow. So deep breath in, we'll just talk about lower extremity veins for now. Big breath in, holding our breath, abdominal pressure rises, and those valves close, preventing any kind of retrograde flow. So now what happens is we take a deep breath in and bear down. If those valves are not coapting or coming together completely, what happens is we get this flow reversal. Whoops. So we actually get retrograde venous flow getting through those incompetent valves. So this is venous insufficiency. Once we breathe normally, venous return is normal and going the proper way. So that high abdominal pressure is actually causing those valves, they're not coming together because they are insufficient and pushing that blood backward. So it's really important that we have healthy venous valves to help prevent that retrograde flow. Here we also have a lack of an augmentation response. So this is augmentation in this lower spectral tracing, and this is a normal response. So we get that aliasing, that wraparound of venous return. So that distal compression propels blood forward. When we have a lack of it, then we know that there is an issue between the site of distal compression and your location. So let's just not much of an artiste here, but if we compress here and my sample volume is up here, then there is an issue somewhere between these sites. So perhaps it's a partial thrombus, perhaps the leg is really edematous and our squeezing of that blood isn't actually getting kind of through to the vein because the leg is so edematous. It could be extremely muscular. Sometimes people tense or tighten, and it's hard for us to actually properly squeeze distal to that, and they tighten up. So we don't actually see that augmentation. So it's important to assess the situation, and is it you, is it the patient, or is there actually an issue? We also know that flow is spontaneous. So down here, we have no color fill in this vein there, and we have no venous flow happening. Where here we see lots of venous return happening. So when there's no spontaneous flow happening, we know that there must be an occlusion, a complete occlusion of that vein. So the thrombus is filling that vein and no blood is actually able to get through. So in conclusion, we have cardiac issues. So if we see pulsatile venous flow, ask the patient more about pulmonary or cardiac issues. If we see flat flow, our job isn't done. It's a proximal outlet obstruction. If it's seen bilaterally, we need to look more proximal to the IVC. If it's seen unilaterally, then we need to look more proximal to where we are in space. We also have that venous insufficiency. If we get retrograde flow during Valsalva, then we know that we can report to a radiologist that the valves are incompetent. We have a lack of augmentation response, so that's going to be a distal issue. And then, of course, we have a lack of spontaneous flow and know that there is a occlusive thrombus happening.